Good morning, guys. So we're here to prepare for test 3, which is going to be covering trauma, bioterrorism, shock, and then all the complications of shock, like SIRS, ARDS, MODS, DIC. I'm not going to spend time on bioterrorism because I don't have the time to spend. Bioterrorism is really just a lot of memorization. There's a wonderful chart in your module that you need to take the time to fill out and study, and then you should be fine, okay? The next thing we're going to do is go over trauma. And one real quick thing. I just want to say this because this video will probably be archived for forever. And so when I'm long and gone from SPJC College, I want people to know, and I don't know if any of you had the pleasure of having Leslie Honig as one of your level 3 instructors. Possibly not, because she retired about a year or two ago, battled cancer, and went home to heaven on Saturday. So we're very sad here at St. Pete College. Just a wonderful lady. But her legacy will live on because she touched so many people that she worked with and so many students. And so her bright light will continue. Okay, so let's get into what we're discussing. Let's first talk a little bit about trauma. And when we're talking about trauma, you know, it can be all types of trauma. We talked about head injuries when we talked about test 1, but this could be chest trauma, abdominal trauma, extremity trauma. What you want to start thinking about initially is triaging patients at a trauma scene or when they come into the trauma center. So what we did was we put the page up here, page 1675. You want to know the difference between a primary and a secondary survey. And you want to make sure you think A, B, C, D, E. You want to think airway, breathing, circulation, and then D for disability, okay? A, B, C, D, E. And so I'm going to let you look at the differences between the primary and secondary survey and what you are really focusing on. And it just makes sense. From level 1 all the way through, we've talked about airway, breathing, circulation, yes? So when we talk about triage, there's this ES scale, and it's a 5-level emergency severity scale, ES1 through ES5. So you know I always make up stupid little ways to remember things. So here's my stupid little way to remember this. ES1, you got to run. This person has already succumbed to cardiac arrest. They need CPR, or they're like bradycardic. They have like shallow respirations. We need to react right now. Then ES2 is almost code blue. So ES2, you got to think, almost code blue. I got to prevent code blue. So this could be somebody with chest pain, multiple trauma, unless they're unresponsive. If they're unresponsive, they go to ES1, okay? And I don't think that they're going to get real tricky and try to trip you up on this at all. ES3, we can wait and see. ES3, we can wait and see, up to an hour. Somebody comes in with abdominal pain, maybe a hip fracture in an older patient, but we have up to an hour to wait and see, yeah? ES4, possibly they walk through the door. ES4, they walk through the door. They're stable, okay? They're stable. This would be somebody like closed extremity fracture, simple laceration, cystitis, something to that effect. So we can even wait longer than an hour to see them. And ES5, I call it jive, okay? ES5, it's jive. Why are you in the ER, okay? Some people, I mean, they were told to come back to the ER maybe to get their staples removed or a wound checked, but most of the time it's the cold, it's the flu, it's the that kind of patient, okay? So ES5, it's probably jive, so they can absolutely wait. What I would encourage you to think about is, though, if we have an adult patient versus a pediatric, where does your heart immediately go? PD. Okay, but if your adult patient has an airway issue and this baby's crying and pink, even if they have a fever or whatever, you're going for that adult, okay? So it's really not age specific. It's airway, breathing, circulation, yes? Okay, we're going to be talking a little bit about trauma. When you have chest trauma, I want to go back here and remind us about the physiology, the anatomy of the thorax, and how we have the lungs in our thoracic cavity, right? And then we have the heart in the mediastinum, which is right in between that. And this is our major pump, and this is our major gas exchange where we get our oxygen. So if somebody has blunt force trauma, let's say that you're traveling in an aircraft 200 miles an hour and it goes off the end of the runway and slams into the road on fire, Okay, I don't know whoever that happened to, me. All right, so what happens is your lungs get smashed between that bony rib cage, and you can actually cause a rupture in the covering around your lungs. Remember, your lungs are covered by the visceral and parietal pleura, correct? One of those lines the thoracic cavity and the other one lines the lungs. And between those two layers is a little bit of fluid and a negative pressure that helps keep your balloony lungs open, right, for effective gas exchange. If something causes a rupture in that, then what will happen is positive air from the outside, atmospheric pressure, will rush in there, and it will deflate your lung, and it will keep deflating it and keep deflating it until this pneumothorax, that's what air in that space is called, starts pushing pressure on the mediastinum, swinging it over this way till it becomes a tension pneumothorax. Now, the gold thing is, in a tension pneumothorax, I'm going to see tracheal deviation. Remember back in level 1 we said, is the trachea midline? If you wait to see tracheal deviation, it's too late. They already have a tension pneumothorax. Does that make sense? So you would want to say, as you're assessing that patient, put your hands on them. Do they have symmetrical chest expansion? Can you hear breath sounds on both sides? If not, we've got an issue. Okay, so back, when we flew, before we even put a chest tube in, you can take a 18-gauge needle, cut off the finger of a glove, stick the needle through the glove, and stick it in this between the second intercostal space, mid-clavicular line, and let that pressure release. Now, it's coming through the needle and then out that little glove so that when the person goes to inspire, that glove prevents air from coming back. It's like a flutter valve. That's in an emergency. You may get tested on questions, and I'm sure you will, let's not say may, about chest tubes, because that's the definitive cure for a pneumothorax, okay? So what's going to happen is they're going to put yes, it's this big. I've had one in my chest, and they don't feel good. They're going to put it in air. We're going to go higher, all right? If it's fluid, we're going to come lower, like at about 4 because of gravity. It's going to be in there and sutured, and then you realize we don't want any air from the atmosphere getting sucked in around it, or that will further complicate the pneumothorax, yes? So they're going to put some kind of a petroleum-type gauze around the insertion site, yes? And then wherever this is attached to the tubing, say it's attached down here, we're going to be taping those connections, because we don't want to have any positive pressure from the air get into this negative pressure intrathoracic space. We want to re-expand that lung. Does that make sense? Okay, so this tends to trip students up. This is just a typical chest tube setup. This is a regular water seal, and this is a dry suction water seal. This is what we flew with because up in the aircraft we didn't want to deal with a bunch of water. It's the same principle. What you're going to see is that this will go into the patient's chest, and then normally the doctor's going to say, well, let's put it to 20 centimeters of wall suction. Now notice there is water down here, okay? It's usually up to about here. I've had this for several years. It's kind of dehydrated. And this is what we want to see bubbling when we know the suction is on. When there's bubbling in the water seal, suction is working and the lung has not fully expanded. It's pulling air out. Now air and any serosanguinous fluid is going to go into these drainage chambers, okay? And what screws students up is there's this other column here that has water in it. We take this little device, of course it's not handy, and here it is. And we would take it and put it at the top of the chest tube, and we would pour water until it was at 15 or 20 centimeters where we want to see the suction, okay? And there's supposed to be a continuous bubbling in that one, okay, in that one. Initially, you'll see bubbling in this, in the air leak chamber, but once we get a good seal, you should not see bubbling in the air leak chamber. Does that make sense? Once we get it in and we've established a negative pressure, you're still going to see bubbling in the suction chamber, but not in the water seal chamber. If after it's been in for several hours, I see continuous bubbling in the water seal chamber, what the water seal chamber, guys, is it's the same principle as if I had this chest tube stuck in a glass of water. Okay? If I stick it in a glass of water, then when I inspire, I can't suck air back up. Does that make sense? So that's all this water seal chamber is. Okay? So if I see some bubbling there after the initial put in, I'm going to think, ooh, there might be an air leak. So start with your patient and work your way out to see where the leak is. And that's the only time we can clamp chest tubes is if we're looking for a leak. But technically, you don't want to clamp chest tubes because it can lead to a tension pneumothorax. Okay? So the one where we have the suction should have a continuous bubbling, meaning that your suction is working. The water seal should only have bubbling initially when you insert the chest tube. Continuous bubbling there means air leak. Are we clear on that? Now there's a thing called titling. As I inhale, I change my pressure and then I exhale. You may see the level of water in the water seal go up and down, like in and out with the tides. That's perfectly normal. Perfectly normal. In fact, when we see it stop totally, we got to listen to the lungs because possibly the lungs reinflated. Let's go get a chest x-ray and maybe we can get this nasty chest tube out of the patient's chest. Does that make sense? Okay, now several things can happen. When they put the chest tube in and it's connected to the drainage system, do I want this high? Where do I want it? Below. I want it low, and I don't want it to be able to get kicked around, right? So you got to be very careful with that. But because we live in an error-prone world, somebody could trip over it, and what could happen is that this could disconnect, and now I have a chest tube out in the wind. So when I inhale, I could be bringing positive pressure air back into my intrathoracic area there, causing another pneumo. So what would you do? Stick it in sterile water, which brings me to the point that everybody with a chest tube should have a bottle of sterile water at the bedside. Yes? If they didn't have sterile water, but they had a cup of coffee or they had a urinal, that puppy's going right in there because I got to prevent air from getting back in there. But the perfect situation would be in the sterile water. You see what I'm saying? The other thing that could happen is that the chest tube could get ripped out. And now I have an opening in my chest, allowing positive pressure from the atmosphere to gain access and build up a positive pressure where negative pressure should be, right? So what am I going to do? Should I cover it completely? No, because that could cause a tension pneumo. So we take a gauze, and we put the gauze on it, and we just tape it three-sided. That means it's kind of going to be like a flutter valve. When I inhale, that gauze will suck into that hole and prevent air from coming in. But because gauze is porous, when I exhale, it'll let any of that trapped air escape to prevent a tension pneumo. Does that make sense? Those are the big things with the chest tube. Okay? Great. Let's go on. Okay, so just know the differences between what what organs are in which area. So if you have chest trauma, you're worried about the heart, the lungs, the major vessels, right? Abdominal, we're worrying about the liver and the spleen that are very, very vascular, okay? Think about you have to roll people because if they have intra-abdominal bleeding, where are you going to see it? You might see Cullen's sign, which is a bleeding around the umbilicus. You might see gray turners when you turn them, which is ecchymosis back there. Both of them indicating intraperitoneal bleeding. Something has ruptured. You've got bleeding. And that could lead to hemorrhagic shock, which is what we're getting ready to go into. Yes? What do you got to be careful about with fractures? Those 6 P's of perfusion. If I have a fracture, it could have disrupted vessels and or nerves. So I want to check, do they have a pulse? What's my cap refill? Is it pale? Is there pain? How about paresthesia? And then finally, paralysis, very good, and poikiliothermia, where they lose vasomotor, or they lose the ability to constrict when it's cold or dilate when it's warm, and they just their extremity takes on the environmental temperature. Okay? So don't get fooled by that, especially if it's a compound fracture. Now you're worried about this bone sticking out, okay? So usually we have to apply traction or some way to keep it from moving to prevent further damage to vessels and nerves. Just like when we talked about spinal cord injury, we have initial injury, we want to prevent secondary injury, okay? Any questions on that? Okay, so like I said, we're not spending a whole lot of time there. The other thing I'm not going to spend time on, because I have you guys got videos and you guys probably got it down by now, are fluid and electrolytes and acid-base ABGs, which I'm sure you're going to have questions about. So if you're not sure about that, we got the handouts and then you have my videos, okay? So let's go and let's start talking about shock. Now, if you have come to any of my seminars, you know that I've told you that shock is not just low blood pressure, okay? Shock is all about not having adequate perfusion. And when Miss B, defines perfusion, which is the supply of oxygen and vital nutrients to the cells and the taking away of the end products of metabolism from the cells, I give you a bunch of P's, right? The pump, pushing the precious prime precisely through the pipes to the point of purpose. That will not be on your test. That is not in your textbook, okay? It's going to be in the textbook I write one day. Okay, so anyway, the pump would be the heart, okay? So that would be cardiogenic shock. The prime, that precious prime that fills up the river that allows the hemoglobin train to go around, would be fluid, so that would be hypovolemic shock, or blood, hemorrhagic shock, okay? And then it has to go through precisely through the pipes, from the arteries to the arterioles to the capillaries. Remember, guys, the capillaries are the only part of the pipe system where gas exchange and nutrient exchange and fluid exchange is supposed to occur, yeah? And then come back up through the venules and the veins. And then also, the pipes? Yeah, okay, so the pipes, problems with the pipes can occur, could be neurogenic, anaphylactic, and septic. So I'm going to break down the shocks per the P's that I use to teach about perfusion. Does that make sense? And remember, we have to have adequate perfusion because we have to have enough oxygen for aerobic metabolism to make ATP. Yes? I feel a need to review that really quickly, okay? So remember, we were created to function in an aerobic state with oxygen. When we have adequate perfusion, all the P's are working, we're going to make 36 to 42 ATP molecules. Yes? Then everything has to break down. Now, what is ATP? That is adenosine triphosphate. That is the energy of every cell, whether it's a muscle cell to contract, a nerve cell to generate an impulse, or a glandular cell to secrete a hormone, whatever it is. If there's not enough ATP, there's cease of function, yes? And the end product of that is H2CO3, which is carbonic acid. Then carbonic acid breaks down into bicarb, which we know is our sponge, the base. And we should have 20 parts of that to every 1 part hydrogen, which is the acid. And that's where your acid base comes in. So a lot of times when somebody goes into like cardiac arrest or piss poor perfusion, that's my other term, when there's not enough perfusion to make urine, that's piss poor perfusion, they're going to go from aerobic to anaerobic, and they're going to start building up acid, and they'll go into metabolic acidosis, okay? But this, if everything's working well, we should have 20 parts bicarb to every 1 part acid, and then eventually that's going to break down into water, which I can either reabsorb and use or excrete as urine, and CO2, which is what I'm going to exhale, which is really important when we start talking about respiratory failure. When CO2, your PaCO2, the amount of CO2 in the arterial system builds up, we are going to have respiratory failure. We can go into ARDS and all that kind of stuff. Okay, so when that doesn't happen, the other option is anaerobic, and that's without oxygen, and that is like 4 ATP molecules and a boatload of lactic acid, which is really going to put you into metabolic acidosis very quickly, okay? So we got to make sure that the pump and the prime and the pipes are all working, doing their job, or we are going to have inadequate perfusion, or what I call piss poor perfusion, because I tell students that your kidneys are the eyes into the soul of the cardiovascular system. They're continuously taking about 1/4 of your cardiac output, filtering it through all the nephrons, which are millions of Mr. Coffee filters, getting rid of the bad stuff, reabsorbing the good stuff. In fact, the next test you guys take will be on renal, okay? So you want to be watching that urine output, especially with people who have shock states, because it's going to tell you what kind of perfusion they have. If they're not at least putting out 30 mils an hour, or more specifically 0.5 mils per kilogram, we are in a continuous shock state, and it's not good, okay? So let's go to this handout, nursing for stages of and types of shock. Okay, so what I want to do is skip over page 1 for a second, because let's define the shocks, and then we'll go into the stages of shock. And I wouldn't spend a whole lot of time, I don't want you to memorize the stages of shock. That's not the purpose, okay? The big things you want to focus on with shock are identifying what is the cause of the shock, what kind of shock is it, and then the nursing care, what you are going to do to help your patient. Does that make sense? Okay, so let's look on page 3 of that handout of stages and types of shock. First of all, we have to identify the shock before we can treat it, and that just makes sense. But let's talk about classifications of shock. Okay, so when you think of shock, everybody thinks of low systemic blood pressure, low mean arterial pressure, low urine output. Vasoconstriction of the vessels of the skin cause cool, clammy, and pale skin. Remember, when the kidneys are not getting perfused, they don't know why they're not getting perfused, but they are going to do a little dance that we like to call razzmatazz. Right? You guys know my little razzmatazz? Okay, so what's going to initially happen is renin is going to be secreted. And renin is going to make angiotensin 1 turn into angiotensin 2. Now, if we have piss poor perfusion, we have limited perfusion, and we've got to decide where we are going to send our perfusion, the limited perfusion that we have. So what we want to do is we want to vasoconstrict, right? We want to shut down, vasoconstrict, supply to non-essential things like my duodenum, my sex organs, and allow the flow that I do have to go to important things like my brain, heart, and lungs, yes? So angiotensin 2 is a very potent vasoconstrictor. It also stimulates the adrenal glands that add to your renals to secrete aldosterone. And aldosterone makes us reabsorb what? It's in the word sodium, S-A-L-T. Where sodium goes, water follows. So we're going to have increased fluid. Listen, our kidneys don't know what the cause of the shock is. They just know they're not being perfused. So bringing your fluid back into the pipes is wonderful if we're looking at hypovolemic or hemorrhagic shock. But if I'm bringing more fluid back into my pipes and the cause of my piss poor perfusion is my pump, and I have cardiogenic shock, that's going to make it worse. Does that make sense? That's why some of the things that we will be doing is giving like ACE inhibitors to prevent this, right? And giving diuretics. So that's the first A. Aldosterone is the second A. And then we have the sympathetic nervous system, right? Which norepi and epi, we have one heart. And the effect on the heart, your beta 1, we're going to have increased heart rate, increased force of contraction. And beta 2, we have 2 lungs, right? And we have your bronchi. And so what that's going to do is stimulation of the beta 2 is going to cause bronchodilation. It's also going to increase gluconeogenesis or glycogenolysis, breaking down of glucose because you're under some kind of a severe stress, and you're going to have pupillary dilation. Okay, so that's what we're going to see. And I went in all that to simply say that is why we see cool, clammy skin, because that vasoconstriction takes the blood away from my skin. My skin's not important at this point. Does that make sense? And we're going to talk about there is one shock where you don't see clammy, pale skin. You actually see warm skin. So what I'm going to tell you is I'm going to nail down, I'm going to give you the big flash points of the specifics and those things that make the shock stand out to differentiate them from other shocks, okay? So in any kind of shock, we're going to see increase in epinephrine levels leading to tachycardia, sweating, reduced cardiac output and vasodilation leading to weak, thready pulse, cerebral ischemia, so we're going to have restlessness, confusion, anxiety, reduced urine output, okay, due to increased aldosterone, plus don't forget about little ADH. If we dry up our pipes, our river starts running dry, then those osmoreceptors tell the posterior pituitary to secrete ADH, which is anti-diuretic hormone, to try to hold on to more fluid. Okay, we're going to go into acidosis. The pH is going to go down, and I already talked to you about aerobic versus anaerobic. I'm going to get nauseous because of this shunting blood away from my GI tract. My BUN and creatinine will start going up because I'm not getting adequate perfusion to my kidneys. And my whatever urine I do have coming out is going to be very concentrated, so high specific gravity. And early in shock, my sodium will go up and my potassium will go down. Later in shock, when the cells start breaking down, that's when you'll see hyperkalemia, right? Because what's normally in the cell? Potassium. Okay, so anytime you think about metabolic acidosis, start worrying about hyperkalemia. And we know that hyperkalemia kills because of cardiac dysrhythmias, yes? So if I know of anybody that's been in prolonged shock for any period of time, I'm really concerned about hyperkalemia. Can I stress that any more importantly? And we know that the only way to treat hyperkalemia is dialysis or a regular insulin drip or Kxalate, but that takes time. Okay, so let's talk about shocks can be placed into 3 categories: pump, prime, and pipes. And sometimes people call pipes distributive shock, and that's fine. I use this P classification because I think it makes it a little simpler to understand. So let's talk about the pump shock. This is cardiogenic shock. This is mortality is like up to 85%. Doesn't that make sense? This is the whole pump that helps push the prime through the pipes to get to the cells to deliver the oxygen, the point of purpose, right? Again, perfusion is the pump pushing the precious prime precisely through the pipes to the point of purpose, and the point of purpose is every cell. Now, what are the causes of cardiogenic shock is heart failure, okay? What can cause heart failure? Well, prolonged hypertension, heart that's been beaten against a high afterload for many years. So they've had an MI, okay? They have cardiomyopathy from a virus, whatever. There's many causes. Could be drug toxicity. But what I want you to understand is there's 2 different types of failure. And you guys learned this, I believe, in level 3. No, level 2 possibly. What's the difference between diastolic failure and systolic failure? In diastolic failure, the ventricles are having trouble filling because they're being stiff and non-compliant. However, it has not affected the ejection fraction yet, okay? They still have a normal ejection fraction. And I don't know if you remember how I told you guys to determine what an ejection fraction looks like is simply when they look at the heart, I'll draw up here. When they look at the heart and they look at the preload, okay, they determine how much blood is in the ventricles prior to contraction. And let's say that there's 100 mils in there. Then the AV valve snaps shut and that blood gets ejected. Okay, if only 40 mils is left, that means there's a 60% ejection fraction. That pump's working well. That make sense? But if they look at it and there was 100 mils to begin with, and when they look at it after systole and there's 60 mils left, that's only a 40% ejection fraction. So when they do an echocardiogram, that is how they determine ejection fraction. What I want you to understand is in diastolic failure, the ejection fraction is normal. In systolic failure, it has trouble filling, so you're going to have high pressures in the ventricle, high preloads, and you're going to have a decreased ejection fraction. Either one of these, for prolonged periods of time, can lead to cardiogenic shock. Somebody who's had an MI, especially if that left main, left anterior descending and have a massive left anterior wall MI, that's your whole pumping surface of your left ventricle. And remember, the left ventricle has to send body from the blood from the tip of my head to the tip of my toes. So if it has been infarcted, it's easy that it could go into shock and not be able to pump effectively. Different antibiotics can cause toxicity and stun the myocardium. And on the right side of the heart, now I told you the left side of the heart can fail too if you've had systemic hypertension for a whole lot of years and that poor pump has been pushing, trying to push through 40 over 90, instead of 120/60, then that myocardium is going to have to hypertrophy, which is going to require more oxygen. So that's a huge cause of cardiogenic shock, is prolonged hypertension, a lot of afterload. And I think if you remember about when we were talking last time, I told you that when the right side of the heart fails, it normally fails because the left side failed first. So when the left side fails, blood backs up from the left ventricle into the left atria out into my lungs. So left side lungs, we hear crackles, we see frothy pink sputum, low sats, increased respiratory rates, and then eventually the lungs that are normally very spongy and the right ventricle doesn't have a whole lot of pressure to push against become very stiff and non-compliant. So if somebody has lung disease or pulmonary hypertension, that right ventricle can fail as well. So you need to know the difference between diastolic and systolic failure as well as right and left-sided failure. Yes, because that will help you all the way through NCLEX to determine what signs and symptoms you're seeing and what would be the right treatment. Okay, clinical manifestations of cardiogenic shock when the pump has pooped out. Remember, the first thing the heart feeds is itself, then the brain. So think changes in level of consciousness. And then circle number 2. This is the key. I'm going to have increased pulmonary artery wedge pressures. Okay, we've already talked about what the Swan-Ganz does, how it goes through the heart, and how it, and I got it stuck with mine, how it actually goes through from the subclavian through the superior vena cava into the right atrium, into the right ventricle, and then it hooks and it goes into the pulmonary artery. And if you think of the end of that Swan-Ganz catheter as a camera, when that mitral valve is open, it's taking a picture of the pressure in my left ventricle. What is the pressure in your left ventricle prior to contraction? What is the load pre-contraction? Preload, okay? So we have gotten away from using the Swan as much because now we have new non-invasive things like called the Cheetah, but that's not what's in your book, so that's not what we're going with, okay? What you need to know is obviously we're going to see decreased cardiac output. The cardiac output should be between 4 and 8 liters a minute. And I always tell students your heart's about the size of your fist, so 5 is a mean. But more specifically, your cardiac index. Remember, you take the cardiac output, you divide it by their BSA, and then you will come up with a cardiac index. A cardiac index of less than 2.5 liters a minute indicates cardiogenic shock. So when you're reading your scenario, you see a low cardiac index, and you see well, first of all, you're going to have something like they've had an MI. There's got to be something that affected the pump. That's going to clue you in, yes? And then you're going to see a high pulmonary artery wedge pressure. What's the normal pressure there? Somewhere around 8. If it gets up past 15, that is really high pulmonary artery wedge pressures. By the way, we don't wedge that balloon anymore, but they still call it a pulmonary artery wedge pressure or a pulmonary capillary wedge pressure. That is equal to your preload. This is the only shock that has high preloads. Do you hear what I'm saying? Because the pump is pooping out. So the fluid is staying there, increasing the pressures. Yes? That's what you got to remember. Okay, so we have tachycardia, but that's not, that we get tachycardia and it's other shocks. Low BP with a cardiac output, but there's no fluid loss. Okay, my blood pressure is dropping, but I'm not losing fluid. That's not normal. Elevated right and left preloads. Okay, dusky skin color, which is not significant just to this one. Delayed cap refill and a capillary wedge pressure greater than 18 to 20. Decreased output less than 4 and a decreased cardiac index less than 2.5. I put 3 stars there when I wrote this, so it's really important. The only shock with increased systemic vascular resistance, okay, that's equal to your afterload, and increased preload, your pulmonary artery pressure, sometimes even your increased CVP, which tells you about the pressure in the right ventricle. Now let's talk about treatment that's specific for that type of shock. Treat the underlying cause. So if they're having an MI, we rush them into the cardiac cath lab. Maybe they can do angioplasty, place a stent, open up the coronary artery and reperfuse the myocardium before it totally infarcts. Or we may have to rush them to the OR to do a CABG. Or if we cut it early enough, maybe we could give them thrombolytics. Okay? Does that make sense? Then the other thing is because the heart is weak and there's no loss of fluid, this is not a kind of shock where we're going to push fluids. We're going to halt fluids, very judiciously give fluids to prevent fluid volume overload. So that's why they usually do hemodynamic monitoring, so we can tell exactly how much pressure is in that myocardium, so we can tell, do we need to give them more fluids? Do we need to give them diuretics to take fluids away? Now, we need to help the pump push. So we're going to give positive ionotropics, right? Remember positive ionotropics? Ions like potassium, calcium, sodium are responsible for contraction. So when you think of an inotrope, it's going to help increase the force of contraction. Dobutrex is one. Dopamine is one, but you got to be careful with dopamine because it can also increase the heart, the blood pressure. If I increase the blood pressure, that's increasing the resistance my heart has to push against. So I don't want to get my blood pressure too high. In fact, I usually am trying to decrease the afterload. I want to take my aorta from this tight, high-pressured systemic vascular resistance, yes, and make it like this. So think about it. How do I make a pipe go from this to this? I give a vasodilator, yes. When you understand the pathophysiology, you can critically think, what do I need to do? I need to give something to unload this heart. Vasodilators. What are my vasodilators? Nitro, morphine, ACE inhibitors. Yes, there's so many. Okay, so nitrite, nitrates cause vasodilation. This decreases the workload of the ventricle. If I decrease the workload of the ventricle, I'm decreasing the myocardial oxygen demand, and that's going to help. Inocor is a great drug. It's a positive inotrope and a vasodilator. That's brilliant. So that increases the force of contraction, but also decreases my afterload. I want to decrease pre- and afterload, so they might have to give diuretics, vasodilators, and then I spoke to you last test about the intra-aortic balloon pump and the LVAD, yes? And now they have a new thing that actually sits in the ventricle, the capella, which actually is, it just looks like a regular catheter, and it has two holes in it, and through a centrifugal kind of force, it pulls blood from right outside of the atria, right in the ventricle, right out the aorta. It just kind of whoosh, whoosh, shoots it straight out. It's pretty cool, and it's just like having a intra-aortic balloon pump in somewhat, except it actually goes into the ventricle. Now, an intra-aortic balloon pump, remember that catheter is going to come through my femoral artery, and it's going to sit in my aorta. Yes? Okay, so I feel the need to draw here. Okay, so let's draw. Let me erase this a second. Okay, so here's my heart. Here's the aorta. Okay, so this catheter device is going to come up, and it's going to hang right here outside the aortic valve. Okay, during diastole, remember during diastole, that's when the coronary arteries on the outside are perfusing the myocardium, and the valves are open inside, and the heart is filling. The ventricles are getting stretched, yes? So during diastole, and this is all going to be synchronized to my EKG. During diastole, which is all through here and there, it's going to blow up this 20-millimeter balloon, which is going to push blood back into the coronary arteries, okay, increase coronary artery perfusion, shoot blood up my carotids, increase cerebral perfusion, which is both good, yes? Then, right when the R wave happens, right at ventricular contraction, this balloon is going to rapidly deflate, and that's going to allow the blood to eject much easier because I've got a wide open artery. So it decreases afterload, okay? So that's why we use the intra-aortic balloon pump. If that doesn't work, they might actually have to catheterize the left ventricle, bring it out of the chest, and use that left ventricular assist device, which is a pump that augments the left ventricle function. And then if that ventricle doesn't come back to functioning, they're going to have to do a heart transplant, okay? So the big things are increasing that cardiac output by positive inotropic drugs and vasodilating, and then unloading fluid. So getting rid of fluid, maybe with diuretics, what have you. Are we good with that? Okay. Now, that is pump shock. Those are the big things you want to remember. Now, when we talk about prime shock, we're talking about what's in the pipes. Well, we have fluid in our river, and then we have that wonderful hemoglobin train that's full of oxygen to take it to the cells, and those are your red blood cells. So in prime shock, we're losing either fluid and or we're losing blood, and you need to know how to tell the difference. So let's talk about hypovolemic shock. This is on page 4, okay? Wait a minute. Pump shock. Was that the next one? I hate to get out of... Okay. All right. Hypovolemic shock. It begins to develop when intravascular volume has dropped by 15%. This is the most common type of shock we're going to see, is hypovolemic. And then they talk about absolute versus relative. I wouldn't spend a whole lot of time worrying about that. It's caused by loss of body fluids leading to decreased intravascular blood volume. Fluid volume. Sorry, not blood volume. Fluid volume. Absolute hypovolemic shock is loss of fluid through hemorrhage, GI, vomiting, diarrhea, a fistula, hyperglycemia, because we know that that dehydrates the pipes, and diabetes insipidus when they don't have adequate ADH and they just, remember I called diabetes insipidus diabetes insidious piss because they just urinate it all out, or excessive diuresis, or burns. That would be an absolute. Relative hypovolemic shock is when that intravascular volume has moved out. I'm sorry, burns, ixay nixay what I said. Relative would be burns. Intravascular volume has moved out of the vascular space into the interstitial space or the intracavity space. We see third spacing like ascites, burns, bowel obstruction, low albumin. We see interstitial edema. The resulting loss of intravascular fluid causes, if I don't have enough fluid in my river, I don't have enough to return it to the right side of my heart, which means I can't get it to the left side of the heart. So I'll have decreased venous return, leading to decreased preload in the left side of the heart. Decreased preload means decreased stroke volume. Decreased stroke volume means decreased cardiac output. Yes? So what am I going to see? Well, poor skin turgor, right? Remember we check over the clavicles. This is where you're going to see a high osmolality. Remember, osmo high, I'm intravascularly dry. And you want it would be over 295. The main constituent of looking at the equation for osmolality is looking at your sodium. Remember sodium, sodium? Did you eat all those chips? Sodium? 135 to 145 is a sodium. High sodium, you're high and dry. Low sodium, you're below sea level, you're wet. It's just like your osmolality. If you double that high sodium, which is 145, that gives you 290. So the normal osmolality is 275 to 295. So above 295, you are intravascularly dry. What's that going to do? It's going to cause you to be thirsty, yes, because of those osmoreceptors. But again, that's only if you have an intact level of consciousness. Decreased urine output, because I don't have enough fluid to get it down to my kidneys. This is where you're going to see decreased less than 30 an hour, or more specifically, less than 0.5 mils per kilogram for 2 consecutive hours. Anxiety, restlessness. You guys, when we say change in level of consciousness, I don't just mean like they become obtunded. A lot of times people become anxious before they become obtunded because their brain's trying to alert them like, hey, this isn't good, go get help, something's the matter. Tachycardia, tachypnea, increased depth of respirations, increased cardiac output because of razzmatazz. This is where norepi and epi are out there stimulating your baroreceptors, your alpha adrenergic receptors. So you're going to have high heart rate and increased force of contractility. Now, if you are high and dry, your hemoglobin and hematocrit will be up. Does that make sense? So that's how you distinguish hypovolemic from hemorrhagic, because it would be just the opposite in hemorrhagic. So with hypovolemic shock, you have high H&H. With hemorrhagic, you would have low H&H. So what's the treatment? I got to fill up my river. I got to get this river flowing again. So if I want to keep fluid in the river, remember we can make fluid move by changing the tone, changing the concentration of the fluid. So remember, I want the fluid to stay in my river, so I want to give the same concentration that's normally there. There's only 2 types. Normal saline, which is 0.9%, and lactated ringers. Now, Remember, iso is so to increase flow. I'm going to give an isotonic to increase the flow of my river. Let me give you a caveat. In shock states, we do not use lactated ringers because blood's going to be shunted away from my liver, and the liver is responsible to break down lactate back into bicarb. And when it can't, I'll have increase in lactate, increase in lactic acidosis. In fact, when we're trying to determine how bad the shock state is, we will draw lactate levels. Okay, that's not going to be on your test. But what will be on your test is what fluid will you use? Normal saline. Okay? And that's going to fill up my river because I have to fill up my river. Once my river gets full, then it'll leak out the little contributory river, little creeks into my ponds, which are my cells. You have to fill up the river in order to fill up the cells. Yes? So how am I going to know that it's improving? Well, I should feel a stronger pulse. Yeah? I should see my blood pressure come up. I should see urine output start to happen. Okay, that's how I'm going to know that my treatment for my hypovolemic shock is better. Okay, and I already told you about that. So on page 5, let's talk about hemorrhagic. Okay, so again, in hypovolemic, the big things to remember, H&H is high, osmo is high because you're intravascularly dry. Hemorrhagic. My H&H is going to be low. Now you can have internal versus external. Just like you can have relative or absolute with your hypovolemic, for hemorrhagic it would be internal versus external. You must identify and stop the source. That makes sense. You got to plug the dam, okay? Otherwise it's all going to come out, that precious prime is going to leave, and there will be no hemoglobin train to deliver oxygen. So what do I mean by internal versus external? Okay, if you see a gunshot and blood is oozing out, that obviously you can see that external hemorrhage. Or if there's a ruptured artery and it's, you can see that. But what you can't see is retroperitoneal bleeding, okay? Or in my situation, when I survived the plane crash, they were worried that I had fractures of my femurs, right? Because my toes were turning that way. What they didn't understand was the tib fib went up behind my knees, totally turned around, and ruptured my popliteal arteries. So I was hemorrhaging internally. And so what was happening was there was increasing blood down in that compartment around my muscle. Okay, compartment syndrome, does that make sense? Anything that gets higher than 15 to 20 is going to compromise the arterial supply. And so what they noticed was I had no pedal pulses. Okay, so if you have any kind of extremity fracture, be worried about compartment syndrome. So what did they have to do? They had to slice me open and let that pressure drop, and they had to give me fluid, and they had to give me blood, and they had to rush me to surgery to do the fem-pop bypass to stop the cause of the bleeding. Okay, so we have to identify and stop the cause of the bleeding. So what we're going to do is we're going to get at least 2 large bore IVs, preferably 14 and 16 gauges, and we're going to give them normal saline. We're going to wide open it. Okay, we're going to just flood that river. Well, again, we're going to use normal saline because if they're in any kind of shock, we don't want to make the liver have to work harder. And blood is compatible with normal saline because of the tonicity. We don't want any of the blood cells to shrink. We're going to type and cross match them, but if we don't have time, we want to give the blood without all the crazy antigens. The only blood that has no antigens that could possibly cause an anaphylactic reaction is O negative, right? It has no antigen, it's O, and it's negative for that Rh antigen. Okay. We're going to give them packed red blood cells to increase their oxygen carrying capacity. It does have a few plasma elements, but not enough. So we're going to talk about, we have to give FFP, fresh frozen plasma, after every 2 to 3 units of packed red blood cells, because we want to have those clotting factors. That's what's in that plasma. And we have to have the clotting factors or they're going to go into DIC and they're going to bleed to death. And we'll talk about that a little later. We may have to give platelets, our thrombocytes. Remember, that's what plugs the holes. And we want to make sure that we're watching these levels. Our thrombocytes should be 150 to 400,000. And once we get enough fluid in there and we have stopped the source of bleeding, we'll start giving albumin. Remember, albumin should be 3 or greater. And albumin is like the moon. It's that big protein that's in the pipes that helps pull the tide, keep the fluid in the river to increase perfusion. If you give albumin before you stop the source of bleeding, the albumin will bleed out with it. Okay, so that's not something you're going to do right away. And that's a hypertonic kind of fluid. All right, does that make sense? So the big thing with hemorrhagic is you're going to see the decreased H and H. And there's going to be some kind of trauma or some kind of reason they're bleeding. Yes? All right, now let's get into the pipe shock. Pipe shock, the first one we're going to talk about is neurogenic. And we touched on this a little bit when we did spinal cord injury in our test for our review for test 1. This is loss of all voluntary and reflex neurological activity below the level of injury. And this is not just spinal shock, which is a transient. This is pulling of blood within the peripheral vessels with no loss of fluid related to massive vasodilation without compensation because there's a loss of central nervous system vasoconstriction. Guys, for this kind of shock, you're going to have some kind of spinal cord injury or the patient got spinal anesthesia. That's what you're going to see, okay? And what it does do, it blocks the ability of the sympathetic nervous system to vasoconstrict, so you have massive vasodilation, yes? So this is the person who loses vasomotor tone, the inability to vasoconstrict, secondary to loss of the central nervous system. So anybody that has a spinal cord injury or they've had spinal anesthesia or drugs that inhibit sympathetic nervous system will inhibit peripheral vasoconstriction. Here's your clinical manifestations. If anything says flaccid paralysis, your mind should go ding, 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 neurogenic. Absence of reflexes below the injury, right? Hypotension, okay, but that's in like all of these. But here's a big one, decreased CVP, decreased systemic vascular resistance, and then you notice I bolded this next one, bradycardia. In every other shock, your body's trying to keep you alive, so the sympathetic nervous system is going to increase your heart rate. Here, we have a cut off of the sympathetic nervous system, so we only have the parasympathetic, the feed and breathe, causing bradycardia, okay? So when you see bradycardia, you're going to think of neurogenic shock. And then remember when we talk about if, like, increased intracranial pressure, you get increased systolic, decreased diastolic, widening pulse pressure, and irregular respirations if there's a head injury. That's what that's all about. But bradycardia is huge, okay? So with neurogenic, you're going to treat the underlying cause. Remember, spinal shock may last days to months. So we have to wait till that resolves till we can see somebody who's had a spinal cord injury just how permanent their injury will be. And the treatment, circle this, vasoconstrictors. Their pipes won't vasoconstrict, so we must do that for them. So dopamine. Sometimes we have to give them norepinephrine, Levofed. That's how bad neuroshock can be. We have to give them the highest, most potent vasoconstrictor, norepi, Levofed. Which ICU nurses, we call that leave them dead, because parts of their body are going to definitely drop off. It's such a potent vasoconstrictor that if they have to be out for any long period of time, the distal fingers, distal toes are probably going to come off because of severe vasoconstriction. Terminates with the return of reflexes, hyperreflexia, and spasticity. Okay? That is neurogenic. Now let's talk, I'm going to come back to septic because it's the Big Mac daddy boy that leads into SIRS, ARDS, MODS. So flip over to page 7, and let's talk about anaphylactic. The key things with anaphylactic is there has to be something that caused your body to have this hyper reaction. There has to be an antigen of some sort. Remember, an antigen is a foreign protein, whether it's virus, bacteria, mold, peanuts, whatever, that makes your body's immune system mount up a response. So I always tell the story like everybody's got that crazy little aunt, mine's Auntie Gin, right? She likes to drink a little gin, and she's crazy, and she's crotchety and ornery, but she's my Auntie Gin. So as long as she's with me, we're good. But if I try to send her over to your house, okay, after about a half hour, an hour, you're going to get really inflamed and go get her out of here. So there's got to be some sort of antigen, either via direct contact, inhalation, ingestion, or injection. That's the most common. And a lot of times it's giving the wrong blood type, right? Of an antigen, whether it's an allergen, drug, food, chemical, vaccine, insect venom. And remember Mr. T? He's like, I pity the fool that doesn't belong in here. I'm going to tag him and destroy him. All your T cells recognize that antigen from previous exposure. They initiate an inflammatory response. They don't just call out the T cells, they call out everybody. It's like they're calling out the Navy SEALs, the Boy Scouts, everybody's coming. You have this severe pro-inflammatory response, release of vasoactive mediators like histamine, right? We know that that causes vasodilation, heparin, which decreases clotting, and your cytokines, pro-inflammatory cytokines. Cytokines are like those people in your family that are really excited about everything. Oh my God, did you hear about so-and-so? And they're always on the phone exciting the whole clan. That's what pro-inflammatory cytokines do, like prostaglandins. I tell students, prostaglandins, think about it. Sounds like prostitute. What does a prostitute need to do to get paid? She has to excite something. In order to excite something, she has to cause some vasodilation. So when you hear prostaglandins, that's a pro-inflammatory cytokine. And again, that's going to cause vasodilation and increased permeability. Circle that. That is the really bad thing. Our capillaries are supposed to be semi-permeable to allow certain things to go out, but it shouldn't be so permeable that it lets all the fluid out and your albumin and everything else. In anaphylactic shock, you leak out of your pipes, literally, okay? So fluid leaks into the interstitial spaces. We have edema, and that edema in the interstitial spaces means there's no fluid in my river and I'm going to run dry, decreasing circulating intravascular volume. The onset of symptoms is usually sudden and can progress to death rapidly unless immediate emergency interventions are given. So, what do we see? Now, obviously, this is going to be one of those things where somebody's exposed to an antigen, and you're immediately going to think anaphylaxis. Remember, cover up your distractors. Read the scenario. Read the stem. What are they asking me? Are they asking me for an identification of the shock? Are they asking me for a priority intervention? And then say what you know and go look for it, realizing that if it's a priority intervention, there's going to be several interventions that you should do. So you're going to say whatever it is, and then you want to make sure there's not one intervention that's higher, like maybe airway, that would keep them alive longer or keep them from dying sooner. That's how you have to process these questions. Okay, so what are the clinical manifestations? Anxiety, dizziness, dyspnea. Circle that one. Dyspnea. Because of all that leaking in the pro-inflammatory cytokines, they're going to have bronchial smooth muscle constriction, bronchospasm. You might hear the stridor. They're going to get severe GI cramps because everything's going to shunt away from the GI. They may have chest pain, edema, angioedema, the real bad swelling of the lips. And again, we're going to be worried about the airway. Urticaria, which are the hives, and the pruritus, which is intense itching. Incontinence and a feeling of impending doom. Hypotension, because of that massive vasodilation, all the fluid's leaking out, so my SVR, the decreasing SVR, and I'm going to have circulatory failure. Guys, every shock is going to decrease my SVR, my systemic vascular resistance, except for cardiogenic. Okay? Every other one, it's going down. Okay, so prevention is the key. Obviously, if somebody has an allergy, they should have an allergic band on. Prioritize, maintain airway. So what you want to do is you want to give them albuterol, or they might use aerosolized epinephrine. And the two drugs that you need to think of are epinephrine, right, and Benadryl. So epinephrine, it's a sympathomimetic. It mimics the sympathetic nervous system. It's going to cause vasoconstriction and bronchodilation. I got to get those airways open. You can give it IM. In fact, if somebody knows they're allergic to something, they should have an EpiPen with them. And the Benadryl is an antihistamine. All those pro-inflammatory cytokines are going to release histamine, which is going to cause further leaking of your pipes, and we don't want that. We got to shut that off. Okay? And then because all the fluid is leaked out, we have to fill up the river again, and you can give normal saline or lactated ringers. It depends. Normally, we're going to stay with lactated ringers. They may give steroids to stop the immense inflammatory reaction. But think of those things: airway, getting epi, and getting Benadryl. Tell you a quick story. I was flying a patient back to India, and when you fly really long flights, sometimes they would book out seats on an aircraft, a commercial aircraft, and we'd have like a cot in there, and then you'd pull these drapes around. Anyway, I had this guy on the ventilator, and we're up in like business class, and the flight attendant comes and goes, "Come back here quick." So I go running back there, and in the middle seats of 5 seats, right in the middle, this guy's going, right? And I knew exactly, so I go running back to my bag. I grabbed the epi, I grabbed the Benadryl, hit him, and he's like, oh, oh. And so then in talking to him, I'm like, so do you have any allergies? Well, the only allergy I know of is nuts, but I didn't eat nuts. In fact, I asked everybody around me, please don't, have nuts around. And he goes, but I was so hungry, and they brought my tray, and there was a little piece of cake, and there was a tiny sliver of an almond on the top of that cake. So he took the almond and the icing off the cake and just ate the cake. But the almond oil had seeped through, and he had a severe, severe reaction, okay? So we saved his life at 40,000 feet, right? It was pretty cool. If we wouldn't have been there, it's not like everybody hangs out with epi and Benadryl in their pockets. So, and he did not have an EpiPen, yet he knew he had an allergy to peanuts. That's called ridiculous. So the patient teaching is involved in this as well. Okay, so now there is, I already kind of talked to you about that. Let's go back to anaphylactic. Okay, so now let's go back, let's go to septic. And septic is starting on page 6, and then I have a whole separate handout about that, because then we're going to talk about how sepsis goes into SIRS and ARDS and MODS and all that fun stuff. Okay, so septic shock is obviously something that's causing an infection. So we have some kind of microorganism. And this is what we call the warm flush shock. That's what I would think about that kind of is the key to identifying this. There's an invasion of microorganisms, mainly gram-negative. That's a very high mortality, but some gram-positive, as in the case of toxic shock. Also may be the result of a fungus or a virus. But first of all, we have some kind of invading microorganism. It could be a CODI-related infection through a UTI catheter or an IV. Release of endotoxins. Microorganisms release these toxins that are toxic to the endothelium, that inner lining of your pipes. Now, the inner lining of your pipes, you guys, when the red blood cells are like skating along, they're bumping up against the endothelium. And the endothelium is supposed to secrete nitric oxide, which is a vasodilator, okay? When they get messed up, when the endothelium gets diseased, like through atherosclerosis or a microorganism that has endotoxins, nitrous oxide is not going to be secreted. An endothelium will, and it leads to bad vasoconstriction, and we don't want that. So this gram-positive or gram-negative microorganism is going to get in there. It's going to damage the endothelium, and again, that endothelium is supposed to be, your capillaries are supposed to be semi-permeable. They become very permeable, and we have leaking out. We have massive vasodilation with selective vasoconstriction. That massive vasodilation is why we see in this shock warm, flushed skin. Plus, they're going to have a temperature. Because anytime a microorganism gets in our body, our hypothalamus resets the temperature, the thermostat, to try to cook out whatever it is. There's going to be maldistribution. These kind of pipe shocks are called maldistributive shocks because the fluid and the blood are where they shouldn't be. There's decreased tissue perfusion, decreased impaired cellular metabolism. Remember, the key to inflammation is vasodilation, which allows fluid into the interstitial spaces. It's not doing any good in the interstitial spaces. Also, during inflammatory response, the body's temp and metabolic rate increases. You do need to know the difference between these terms. Sepsis is systemic response to either a suspected or documented infection. Severe sepsis is sepsis, that response to suspected or documented infection, complicated by organ dysfunction, whether it's the kidneys, the lungs, the heart. And then septic shock, right, is that third level when you start seeing hypotension with a suspected or documented infection and some organ dysfunction. And this hypotension can persist despite, please circle that, despite fluid resuscitation. You're giving fluids and your pressure is not coming up because it's all leaking out of your leaky pipes. Some other areas of the body will be hyperperfused, you'll be warm, while others will be underperfused. There's massive peripheral vasodilation. This is why we get that pink, warm, flushed skin. Initially, there's a real hyperdynamic state, increased cardiac output. But because my pipes are leaking, I'm going to have decreased systemic vascular resistance. Increased intravascular fluid shift to the third space. So all my fluid in my river is leaking out into the interstitial space, leaving my blood to get thick and clotty. Hear what I'm saying? So I'm going to have increased viscosity, so increased chances of DVTs, pulmonary emboli. Microemboli, which are small emboli, will start to form in the smaller capillaries. Platelet activating factor leads to decreased tissue perfusion. This is where we start seeing DIC, and we're going to talk about that in a minute. So what am I going to see in septic shock besides warm, flushed parts of my skin? I'm going to see increased temperature because of pyrogenics, right? That microorganism is going to crank up my body's thermostat because I'm going to try to cook it out. Increased white count, right? The count should not be higher than 10,000, so I'm going to see it being higher than 10,000. And what does your body do when you have an acute infection? It screams to the bone marrow to send out everybody, even the immature baby bands. So I'll start seeing a shift to the left, increased band neutrophils. Increased metabolic rate, increased heart rate. This is where you can like almost see the heart pounding out of their chest. It's a very hyperdynamic state. You might actually initially see that 4+ bounding pulse that not many people get to see. You should not see a ba-boom, ba-boom, ba-boom. That's a 4+ pulse in such a hyperdynamic state. Pulmonary edema is going to occur because of the endotoxins causing leaking. And when my pulmonary capillaries start leaking, that means fluid is going to leak out of the capillaries, right? It's going to leak out of the capillaries. Here, I'll blow it up a little bit. There's your alveoli, and there's your capillaries. Fluid's supposed to be in here. Now, if my capillaries start leaking, the fluid's going to go into the interstitial space, and eventually it's going to get into my alveoli. I'm going to hear crackles, decreased SATs, okay? Now, what happens is this fluid is going to make the surfactant be non-usable. It's going to rinse out my surfactant. What is surfactant? That is that phospholipid that helps line the alveoli to keep them open. So it's like the first time you go to blow up a balloon, it's very difficult. Once you blow it up, your spit's in there, so you let it come back down, and that balloon never totally deflates. There's always a little bit of air in there, and the next time you go to blow it up, it's much easier. That's what surfactant does. It keeps the alveoli, which are the air, that's the only place gas exchange occurs, at the alveolar capillary membrane. It keeps them open. Well, if I wash out that surfactant, then what I'm going to end up with is atelectic alveoli, okay? And I could have all the blood in the world coming through. There's no oxygen going to get down there. Or because my blood is getting thick and clotty, I might have oxygen in my alveoli, but a bunch of clots preventing blood from going by. So I'm going to have decreased gas exchange. When you have blood going by but no oxygen, we call that a shunt. And when we have no blood going by but we have the alveoli, that's called increased dead space. All right, so we're going to be using that when we start talking about ARDS. All right, the other thing we're going to see eventually is pulmonary edema. Respiratory failure usually develops in 85% of patients with sepsis. That's where we get into ARDS. Decreased urine output and metabolic acidosis from the built-up of lactic acid. Because they can't get oxygen to the cells, they switch from aerobic to anaerobic metabolism. Yeah? Okay, turn to page 7. The criteria for the diagnosis. You can either have hypo or hyper core temperatures. So either greater than 100.9 or less than 97. I think I would spend some time memorizing these, okay? Heart rate greater than 90, tachypnea. Now, next to tachypnea, write a low PaCO2, because sometimes you'll see a low PaCO2 less than 35, because they're blowing it off. They're trying to compensate for that lactic acidosis. Either leukocytosis or leukopenia, so either greater than 12,000 or less than 4,000. Arterial hypotension, where your systolic goes below 90, and the mean arterial pressure, and remember, your mean arterial pressure is 1, 2, 3. Your systolic plus 2 times the diastolic divided by 3. It should always be greater than 60. Here it's going to drop less than 70, or you're going to see a decrease in the systolic blood pressure of greater than 40 millimeters of mercury. Paralytic ileus, because there's going to be no blood to the GI tract, and oliguria, okay, again, for more than 2 consecutive hours. Treatment. I got to get that river flowing, so I want to get a lot of fluids in there. Within the first 6 hours, I'm going to be giving crystalloids, so that'd be my isotonic solutions. I want to get the CVP. which is what measures the right-sided heart pressures. It gives you the idea of the preload on the right side. We got to get that CVP up to 8 to 12, okay? And then we might start giving colloids, like albumin or whatever. Identify and treat the cause of the organism. This is where that person comes in and we pan culture everything, don't we? We pull things out, we culture them, we culture the blood. I remember when my dad went septic, I think I told you before he had that, he had back surgery and they caused him to be paralyzed. But anyway, so when he was in there, they asked me, the girl was drawing the blood cultures from his right aorta. She goes, do you mind if I use the same site? I'm like, what is your protocol? No, you can't use the same site. What if that's contaminated? You're supposed to do a blood culture from 2 different sites, 15 minutes apart. Otherwise, they might be treating like a staph infection because you pulled it off of where there was staph. So you got to watch people, okay? You're the nurse, you're the patient advocate. No, you're going to use 2 different sites, like it says, 15 minutes apart. We're going to culture urine, we're going to culture sputum, anything we can, and then we'll send that to cytology to try to figure out what the causative organism is. And while we're flooding them with fluid, we've got to hit them with broad spectrum antibiotics to try to kill whatever this microorganism is that's causing this endotoxic damage to our endothelium, causing leaking pipes. Okay, do not let this interfere with initiating broad spectrum. So when somebody's septic, yes, we want to try to get all the cultures first, but if you go to get those antibiotics up there, get them in, because that's what's going to save this person's life. Support measures to maintain hemodynamic stability. So these people are going to get vasopressors, and these are the people that need norepinephrine. They're so leaky that they're going to get norepinephrine. It's the first drug of choice when hypotension persists. Now here's the key, guys. After you've given them adequate fluid resuscitation. So we want to see that CVP up between 8 and 12 with crystalloids before we give them the norepinephrine. Dobutamine if needed, because after a while, you guys, whatever this bacteria, whatever this microorganism is, it will have a myocardial depressant effect. So now we start having pump shock too. So they may have to get put on dobutamine. And intravenous hydrocortisone. Steroids are very controversial still in septic shock, but we have to mention it. Okay, go to the handout, please, that says sepsis, SIRS, MODS, ARDS, blah, blah, blah. Obstructive shock would really come more in trauma. And obstructive shock means that's what I was telling you about my compartment syndrome. It's bleeding internally. Or the other thing that can happen is you can have obstructive shock from a pneumothorax that becomes a tension pneumothorax. It's anything that obstructs outflow. So yes, more in the lines of trauma, love. Does that make sense? That's why I hit those things in trauma. Yes?
With the SIRS criteria, was it 2 or more, or how does that fall?
2 or more for the SIRS criteria, yes. And we're going to go over that again because it's so important, okay? So level 4, sepsis, SIRS, MODS, ARDS, and ARF, which is acute renal failure. Sepsis is a systemic inflammatory response to a suspected or documented case of infection. The most common cause is gram-negative, but we did talk like there are gram-positive, like toxic shock. Other potential microorganisms could be viruses, fungi. The clinical manifestations, this is what you were just talking about, darling. 2 or more of the following as an acute change. 1 must be abnormal temperature or leukocytes. So one of the 2 things, you might have an abnormal temperature. My dad's was low. So they were not thinking, I'm like, listen, that's way lower than his normal is, or high. So the temperature greater than 100.9 or less than 97, a heart rate of greater than 90. His was 100 and he was on beta blockers. Tachypnea, again, respiratory rate up and or the PaCO2 down below 35. Altered level of consciousness, positive fluid balance, greater than 20 mils per kilogram a day or significant edema, and hyperglycemia, okay, greater than 140 in the absence of diabetes. This person's in a hypermetabolic state and their liver and everything is trying to give them glucose, but that's only going to potentiate it because what do bacteria like to eat? Glucose. Okay. Inflammatory variables, that's where you get the leukocytosis or the leukocytopenia, so greater than 12 or less than 4,000, and a shift to the left, greater than 10% bands. CRP, the CRP is your C-reactive protein. That is a protein that the liver secretes whenever there is inflammation. So a positive C-reactive protein is a sign of SIRS and sepsis. Here's another one, increased procalcitonin. Okay, there's a diagram down that you can look. Nobody has adequately been able to explain to me, because nobody really understands why procalcitonin goes up in sepsis, but it is a huge marker of sepsis. They're going to draw a procalcitonin level, and if it's up, even before some of these other things happen, they're very concerned about sepsis. Hemodynamically, the systolic is going to be below 90, or it's going to have dropped greater than 40 millimeters of mercury, mean arterial pressure less than 70. Okay, so septic shock is the presence of sepsis with hypotension despite adequate fluid resuscitation, along with inadequate tissue perfusion, which leads to tissue hypoxia. Again, when we get to tissue hypoxia, they've gone from aerobic to anaerobic metabolism. It has three major pathophysiological effects: vasodilation, maldistribution of blood flow, and myocardial depression. In severe sepsis, septic shock, the body's inflammatory response is incredibly exaggerated because of all those things we talked about. The endotoxins that are released by the microorganisms stimulate the body to release cytokines, those things that excite the body, like tumor necrotic factor and interleukin-1, and a pro-inflammatory mediator, prostaglandins, that crazy prostitute that leads to vasodilation, substances such as platelet activating factor, which is going to lead to clotting, results in microemboli and obstructions in the microvessels. All of these responses result in damage to the endothelium of the pipes, vasodilation, leaky pipes, increased capillary permeability, and the neutrophils and platelet aggregation and adherence, and they start forming around the damaged endothelium. Respiratory failure develops in 85% of clients with sepsis, and 40% will actually go in to develop acute respiratory distress syndrome. Clinical manifestations: presence of invasive microorganism, changes in level of consciousness, decreased urine output, all the things we already talked about. Metabolic acidosis. We're going to hit them with the IVs. We're going to give them albumin eventually, not right away. You can read through there. But what our endpoint for fluid resuscitation has to be to get a CVP up between 8 and 12. Keep that mean arterial pressure greater than 65. And again, go with urine output. I want to see at least 30 mils an hour or 0.5 mils per kilogram. The drugs here, again, it's caused by a microorganism. We need to kill it. So once we've done pan culturing, we're going to hit broad spectrum antibiotics. Vasopressors, because my pipes are leaking. So norepinephrine is the first drug of choice when they're unresponsive to adequate fluid. So if you had any question about what is your first line, fluids. Okay, yes, norepinephrine, but I got to get enough fluid in the river to get that CVP up between 8 and 12. Vasopressin, which is pitressin, may be added for clients with septic shock because the body gets depleted of that after a while. Positive inotropic drugs, we already talked about, dobutamine. Anticoagulants, these people are going to be in a hypercoagulable state. So they might get, they'll be on DVT prophylaxis, Lovenox. They're going to try to do stress prophylaxis, proton pump inhibitors, histamine blockers. Now, systemic inflammatory response is a systemic inflammatory response to a variety of causes. A lot of the times we have SIRS because of sepsis, okay? But you can get SIRS for other reasons. Do you hear what I'm saying? If you have sepsis, you have SIRS. You will always have SIRS with sepsis. But because you have SIRS does not mean it's only caused because of sepsis. Do you hear what I'm saying? Sepsis is always an inflammatory response. But you can have this systemic inflammatory response by other things, like an infarction, post-OB causes. We have a whole SIRS thing here. Where is it? DIC. SIRS ARDS mods. This is what I'm looking at here. Okay, hold on. It'll come to me. From the flow diagram below, look at the relationship between sepsis and SIRS. Oh, here's your other causes of SIRS. Duh. Trauma, burns, pancreatitis, okay? But anytime you have sepsis, which could be fungal, bacterial, you're going to have SIRS. Okay, and I think that screws students up. I want to make sure you guys understand that. So triggering mechanism for SIRS could be mechanical tissue trauma like burns, crush injuries, surgical procedures. So after my plane crash, which within 24 hours, I looked like a 300-pounder, man. All the fluid had extravasated out, okay? Severe SIRS. Abscess formation, whether intra-abdominal or extremities, ischemia or infarcted tissue, like pancreatitis and MI, peripheral vascular disease, global diffusion deficits, post-cardiac resuscitation, microbial invasion of bacterial, viruses, etc. Clinical manifestations. You must remember that sepsis is a common cause of SIRS, but not the only cause. Excess of chemical mediators. We talked about all those cytokines. It causes widespread endothelial injury, and my capillaries are going to leak, causing tissue edema. Okay? Some of your neutrophils can get entrapped in your microcirculation. When we talk about the microcirculation, that's the circulation out to the farthest areas of your body, like your fingers, your toes, okay? The small vessels in my renals, in my brain. Transition from SIRS, which is the systemic inflammatory response, to MODS. What does that mean? Multi-organ dysfunction syndrome, which you have to have how many organs dysfunctioning? 2. So listen to what's coming out of my mouth right now. If you have to determine a patient who has MODS, they have to have 2 different organs failing. So if it says that one of the options would be like a decreased urine output and increased BUN and creatinine, that's only talking about my kidneys. But if it talks about an increased BUN and creatinine and a decrease of PaO2, that's 2 organs. That's MODS. You hear what I'm saying? Okay. That's how you got to remember that. All right. So for MODS, there's no clear-cut continuum of going from SIRS into MODS, but what MODS means is more than one organ. So a lot of times cardiovascular dysfunction will see a decreased systemic vascular resistance, their blood pressure will drop, their MAP will drop, but the heart rate will go up, the cardiac output will try to go up to try to maintain some kind of perfusion. Lung dysfunction, this is a common one. We're going to talk about ARDS. Because of the fluid backing up, it's going to cause pulmonary edema. Okay, so we're going to have lung dysfunction, VQ mismatch. All that means is ventilation is your alveoli, perfusion is your capillary. There should always be 1 unit of alveoli full of oxygen for every 1 unit of capillary full of hemoglobin. But if I have a pulmonary emboli, that's causing perfusion problems. If I have atelectasis, that's causing ventilation problems. So that would be a VQ mismatch. That's all that means. And refractory hypoxemia, a PaO2 that I can't get above 60. GI dysfunction, mucosal ischemia. Now listen, if my GI tract is not working and I don't have good perfusion down there, all my normal flora, the normal bacteria that should be coming out when I have a bowel movement and helps break down food and stuff, is going to translocate out of my GI tract into my pipes and cause further septicemia. Okay, so we want to try to get the GI tract protected and working as soon as possible. Liver dysfunction. Remember, the liver is what conjugates bilirubin to help you get it out of your body. So if my liver's not working because of poor perfusion, my bilirubin's going to go up, all my liver function tests are going to go up, ALT, AST, GGT, and my ammonia is going to go up. And albumin will go down. Why is albumin important? Big albumin sits in the pipes and holds the fluid in there. Central nervous system dysfunction. You're going to have acute changes in their level of consciousness, fever. They may have seizures. Renal dysfunction, okay? There's going to be, and we're going to, I don't really want to break this down too much, but usually it's because of pre-renal. We don't have enough perfusion getting to the kidneys. So you got to try to increase blood flow to the kidneys. You're going to see increase in BUN, increase in creatinine, increase in the BUN and creatinine ratio. Remember, your BUN should be less than 20. The BUN is the end product of protein metabolism. Creatinine should be 1 or less, or 1.3 the book says. That's the end product of muscle metabolism. And your EGFR, your estimated glomerular filtration rate, should be always higher than 60. The urine-specific gravity is going to get high because you're dry. All right? All that fluid is not in your pipes, it's out in the interstitial space. Okay. Go to MODS. Okay, that's on page 5. This is the failure of 2 or more organs in a severely ill client who's hemodynamically unstable despite fluid resuscitation. It is a result of SIRS. And remember, if you're septic, you have SIRS, but there's other reasons for SIRS. Okay, so MODS is a result of SIRS, that systemic inflammatory response. The transition between SIRS to MODS is not always clear-cut, okay? And it doesn't always go first the kidneys, and then the heart, and then the lungs. No, it depends on what that person's comorbidities are. If they already have COPD, they're at high risk for their lungs failing. If they've already had an MI, then it's probably the heart. Or if they've had renal disease, it's probably the kidneys. Do you see what I'm saying? So I wish it was a clear-cut. I could say A, B, C, D, but it's not. But as long as you understand what's going on with SIRS, it will help you determine how they get into MODS, okay? In both of these syndromes, the respiratory system is usually the first to show signs and symptoms. Think about how vascular your respiratory system is. As more organs fail, 3 or more, the mortality rate increases to 70 to 80%. So the cause of MODS is any injury which results in SIRS, and SIRS is that release of those chemical mediators that cause direct damage to the endothelium, right? So now we have leaking, hypermetabolism, increased vascular permeability, leaking of not just fluids but proteins and chemical mediators out of your river into the interstitium. So now I'm going to see interstitial edema. If I don't have enough fluid in my pipes, I'm going to have hypotension, decreased tissue perfusion, and then if I don't have enough fluid in my river, it's getting drier and drier, hypercoagulability, I'm going to have microemboli. And that leads into DIC, which we'll talk about. And it leads to shunted blood flow away from your organs. Clinical manifestations are obviously going to be specific to which organ is failing, but they're based on inflammation, tissue hypoxia, and hypermetabolism. Remember, the respiratory system usually fails first, so clients with ARDS, acute respiratory distress syndrome, need aggressive pulmonary management with mechanical ventilation. The 2 types of pneumocytes are both affected. Type 1, which is the alveolar cells, they're destroyed, okay, because fluid comes back up in, and those prochemical mediators can actually damage them. And the type 2 cells are damaged, and those are the ones that produce surfactant. So now I have stiff, non-compliant, collapsing lungs. Now I have an increase in shunting of blood away from those alveoli, and I have increased capillary membrane permeability. So now, again, I have fluid leaking out of my capillaries into the interstitium. I can't get oxygen from my alveoli onto my hemoglobin train that's full of CO2, okay? I have a VQ mismatch, and my O2 is going to go down and my CO2 is going to rise, okay? This decreased oxygen availability to the myocardium, the body tries to compensate by massive vasodilation, which results in decreased systemic vascular resistance, decreased blood pressure. But the baroreceptors that are sensitive to pressure change in my carotid and aortas will release ionotropic and chronotropic factors to try to improve my cardiac output. So you'll see the patient tachycardic and warm, but they have a decreased SVR. All right, other manifestations are decreased capillary refill, increased right preload, increased left preload when the heart starts failing. Acute changes in mental status are early signs of SIRS and MODS. Now, I wanted to get to MODS. Okay, it's coming. Okay. Acute renal failure, again, razzmatazz is going to be stimulated. You can read through that. We already went through it. The GI system plays an important role in the development of MODS. As the blood is shunted away from the GI tract, you're going to start seeing decreased brow sounds. You might start seeing abdominal distension and paralytic ileus. The client's at risk for ulcer formation. Also allows the normal intestinal flora, like I said, to translocate into the bloodstream. The client's hypermetabolic. They'll try to keep up with the caloric demands. And then the caloric demands by releasing stored glycogen so that it can be converted to glucose by glycogenolysis. When the glycogen stores are utilized, the body will then use its amino acids. So now I start breaking down muscle. Okay, so you're going to see hyperglycemia early in MODS. The liver, hepatic. The increased demands put on the liver to convert lactate from anaerobic metabolism to bicarb, okay, is going to place the liver at high demand. The liver eventually begins to fail, loses its ability to synthesize proteins, specifically albumin, so I don't have that oncotic pulling pressure in the river. Fluid's going to further leak out into the interstitial spaces. It's not, but here's the thing, you would think you should give albumin during this time. When the pipes are leaking, don't. It'll just leak out and pull more fluid with it. Late in MODS, client will become hypoglycemic. The liver also synthesizes your blood clotting factors. So if my liver's not making my blood clotting factors, what am I at high risk for? Bleeding. And when I bleed, then I'm going to clot, and we're going to talk about DIC. Electrolyte imbalances. Initially, you'll have hypokalemia. Release of epinephrine and norepinephrine will drive the potassium into the cell, but as the cells break down, it could lead from anaerobic metabolism, it can lead to hyperkalemia, and all your other things, hypomagnesemia, hypocalcemia, hypophosphatemia. And if you need to review signs and symptoms of those, the handouts are over there, or my lectures on fluid and electrolytes are on the Commons. Remember, if there's more than 3 organs fail, the diagnosis is really of mortality is up to 80%. The most common cause of death is sepsis. So what is it we need to do early? Recognize that this person is in SIRS or sepsis. Prevent and treat infections. Prevent hospital-acquired infections. Early surgical procedures for draining abscesses. Use strict aseptic technique for all dressing changes. Now there's more and more focus on getting people out of bed, getting them ambulating, getting them coughing and deep breathing, using that incentive spirometer. Guys, hospital-acquired infections like pneumonia and UTIs cause sepsis. So in level 1, when we were barking at use the incentive spirometer, teach them how to use the incentive spirometer, get them out of bed and walk them, there's no joke, okay? We don't want them laying in bed with urine stasis in the kidneys and the renal pelvis causing UTIs that lead to sepsis. And you do want to be very strict aseptic technique when you're doing any kind of sterile procedure like PICC line changes, central line changes, trach care, because there's bacteria everywhere, right? So prevention and early detection, maintain oxygenation. Hypoxemia frequently occurs with SIRS and MODS. Interventions to decrease oxygen demand, which we'll talk about, and increase oxygen supply. These people are going to be on a ventilator. They'll be intubated on a ventilator. We're going to sedate them, give them meds for pain. We got to make sure they have enough blood, give them a high hemoglobin. And then we're going to talk about a specific setting on the ventilator called PEEP to try to open up those alveoli to increase effective gas exchange. Nutritional and metabolic support. These people are probably, we try to get a tube down and get the GI tract to give them their protein, to give them their nutrition, so that they don't transmigrate the bacteria. But if it's totally shut down, we're going to have to give them TPN. Okay? They're in hypermetabolic states. All right, turn the page. Appropriate support for failing organs, the lungs. Okay, what is ARDS? This is the way I like, I forget his name up there in the respiratory department. He's fabulous, and I just can't think of his name right now. But he talked about a mnemonic for ARDS. ARDS means increased airway pressure, the amount of pressure it takes to give the patient a breath. Peak inspiratory pressure, it should be less than 20, okay? And it goes up. Refractory hypoxemia in the blood leads to refractory hypoxia. So if you are drawing ABGs and you see that a person's PaO2 is less than 60, when they're already on an FiO2, right, a fraction of inspired oxygen of greater than 60, that's ARDS, okay? Diffuse infiltrates. This fluid leaking out of the pipes, going into the pulmonary interstitium, causes pulmonary edema, and it whites out. On an X-ray, it looks like a whiteout. So diffuse infiltrates in my lungs, and the S is to save the good lung. What other areas of good lung we need to save them? We want to prevent barotrauma, any pressure-related injury to the lung. So let's talk about acute respiratory failure. It's not a disease, it's a symptom or underlying pathology that compromises lung function. So it's caused by something else. O2 delivery, CO2, or basic metabolic state. It will result in a compromised gas exchange in one or more of the following ways. So, insufficient amount of oxygen being transferred to the blood, so we have hypoxemia, a PaO2, and I have it in bold there, of less than 60 when you have an FiO2 of greater than 60. So this is usually somebody we've had to put on the ventilator, and we keep cranking up the FiO2 and cranking up the FiO2, but when we do ABGs, their PaO2 still remains below 60. The causes, it could be pneumonia, toxic inhalation, massive pulmonary emboli, inflammatory states like SIRS, hepatopulmonary syndrome, ventricular septal defect. The one you guys are going to be looking at when you're talking about SIRS or ARDS, this test is SIRS, and probably SIRS secondary to sepsis. Clinical manifestations, they're going to become dyspneic, tachypneic, prolonged expiration, using accessory muscles, trying to get air in, maybe even nasal flaring. A late sign would be cyanosis. Guys, if you wait to see cyanosis, that means that your SATs are 80 and your PaO2 is 60. That's where it has to be to see cyanosis. So don't wait for cyanosis. Look at like uneven chest expansion, respiratory rate increasing, difficulty breathing. They're going to be agitated, disoriented, they'd be confused, decreased level of consciousness. Heart is going to increase, hypertension because of razzmatazz. They'll have cool, clammy, and diaphoretic skin. Late would be dysrhythmias and hypotension. Okay, so inadequate CO2 will lead to hypercapnia. The PaCO2, remember that this PaCO2 should be between 35 and 45. Once it starts getting up above 45, it's going to drop your pH below 735. You're going to go into respiratory acidosis. Some of the causes could be asthma, COPD. You could read through all that, spinal cord injuries, severe head traumas, pneumothorax, Guillain-Barré. Not just sepsis can cause acute respiratory distress syndrome, okay? But SIRS is what is the problem. SIRS is what leads to it. So, clinical manifestation of ARDS. Dyspnea, they'll have to be orthopnic. A lot of times they're leaning forward, trying to get that oxygen down there. They might use some purse slip breathing. If it's usually tachypnea, if they start doing bradypnea, they're circling the drain. Shallow respirations, they're not moving good effective gas. They might have a morning headache. Progressive somnolence, that's a late sign. Cardiac dysrhythmias, hypertension, bounding pulses. Neuromuscular, muscle weakness, decreased deep tendon reflexes, and possibly even seizures. All right, collaborative care. These people are going to have to be on oxygen. They're going to start out probably on a non-rebreather, and then eventually we're going to have to probably put them on a vent. But we want to prevent that. So again, you want to mobilize secretions, have them get enough fluid, use the incentive spirometer, have them cough and deep breathe, do chest physiotherapy, make sure you're suctioning them if we need to. Now, before we put them on a ventilator, a lot of times they'll put them on CPAP, continuous positive airway pressure. They have to get a tight-fitting mouth and or nose mask, and then what they do is they push air into the airway. So it's kind of like you're driving along at 50 miles an hour and you immediately stick your head out of the window. It's not hard to breathe, is it? Because all that air gets shoved at you. That's what continuous positive airway pressure is. It's just pushing air so you don't have to work hard to get that oxygen and air down there, okay? Now, they also have BiPAP, which is giving you positive airway pressure as you inhale, and that as you exhale, it also gives you a lesser pressure to try to keep those alveoli open at the end of expiration. And if that doesn't work, we definitely need to get them on a vent. Some of the drugs they're going to use, albuterol, solumedrol, Lasix to get any extra fluid out. If this person is having a hard time breathing and we're going to have to put them on a vent, we want to give them anti-anxiolytics like Ativan, morphine. They're going to be on antibiotics to treat infection. Now, this is the Mac Daddy, acute respiratory distress syndrome. It's a sudden and progressive form of what we were just talking about, acute respiratory failure, in which the alveolar capillary membrane is damaged and leakage of plasma fluid into the pulmonary interstitium and into the alveoli, intercellular spaces. The severity is measured by a ratio that exists between the PaO2 and the FiO2. Don't worry about that. Just realize that it's occurring if the PaO2 is less than 60, if you have an FiO2 of greater than 60. There's 3 pathological changes in ARDS. Injury, exudate phase, that usually occurs 24 to 48 hours after the initial injury. When capillary membrane permeability increases, allows leakage of plasma fluids into the pulmonary interstitium. Also, there's a decreased production of surfactant. That's what I already showed you. Then we go into the reparative proliferative phase. It begins about 1 to 2 weeks after the initial injury. During this phase, there's an increase in amount of white blood cells. Okay, I wouldn't worry too much about that. And then sometimes, if that keeps occurring after several weeks, it becomes fibrotic. The lungs become fibrotic and they're scarring, and now they're going to be very stiff and non-compliant, and you're not going to be able to ventilate the patient. Turn to page 9. By the way, before I forget, if we run out of time, go back to your shock handout and just review the stages of shock. That's not so important. The thing is that you always want to pick up shock before it becomes irreversible. Okay, let me see. Is that it on? No. Troubleshooting with ARDS. We got to put them on a ventilator. They changed this handout, guys, so I'm sorry. Okay, so ARDS, the most common cause is sepsis. We got to talk about clinical manifestations. Initially, they're subtle. The client may not exhibit signs of respiratory difficulty, or they may show signs of tachypnea, dyspnea, cough, restlessness. When you listen, you're going to start hearing crackles. Why? Because fluid is leaking into the alveoli. When you do your ABGs, it will initially reveal respiratory alkalosis because they're hyperventilating. At that point, edema might not see the edema on an x-ray. But as ARDS progresses, the client will exhibit signs of respiratory distress like tachypnea, use of respiratory muscles. The pulmonary wedge pressure does not increase because it's not an underlying cardiac etiology. So this is pulmonary edema, right? Not caused by my heart, okay? So if I have a swan in a patient and their pulmonary wedge pressure is not greater than 15 and I'm having low PaO2s and high CO2s, it's due to ARDS. It's not cardiogenic in nature, okay? When ARDS progresses, it's associated with profound respiratory distress, which requires treatment by endotracheal intubation and putting them on positive pressure ventilation. Okay? Clients will progress into a state of metabolic acidosis. Now, that should say respiratory acidosis. Sorry about that. That's a typo. All right, administration of oxygen. The goal is to correct hypoxemia. What's the normal PaO2? 80 to 100. With ARDS clients, initially, oxygen is delivered by high-flow systems with a Venturi mask. Then we go with CPAP, BiPAP, and then eventually endotracheal. If the FiO2 is greater than 60 for more than 48 hours, the chances of oxygen toxicity will increase. So we're going to try to use other measures to try to open up those airways, get that fluid out of their lungs. Positive pressure ventilation. It's common for PEEP to be started at 10 to 20 centimeters of water for clients with ARDS. You're going to get tested on PEEP, I guarantee you. PEEP is just a setting that they can add to the ventilator. I'm not going to spend time talking about, tidal volume is the amount of air in and out, and then you set a rate, how many times the patient's going to get a breath, and then what the FiO2 is. What you need to know, and there's a great, I put it up here somewhere, ventilator bundle, what you have to do when a patient's on a ventilator, page 1668, like keep their head abed at 30 degrees, suction them, keep their airways clean. They get oral care with chlorhexidine every day. There's a ventilator bundle you need to know about, okay? So it's on page 1668. In the 10th edition, it's 1623. But I want to talk about PEEP. And what PEEP does is, by the way, all that stuff is on here too about keeping them from having ventilator-associated pneumonias. Okay, so PEEP is when you give when the ventilator gives a breath, it's going to give a tidal volume, amount of volume in, and then the person's going to exhale. As ARDS is occurring, it's going to cause a higher and higher amount of pressure in order for that ventilator to get that same tidal volume into the lungs. And your tissue can get damaged because of high pressures. It's called barotrauma. We don't want to have high pressures, and we measure the pressure that it takes to deliver each breath. When that peak inspiratory pressure gets above 20, we're worried that we could actually injure the lungs from the high pressures of the ventilator. So what they'll do is they'll put them on pressure support, which helps, just like as they take the breath, it's like again, sticking your head out the window, and the air is just rushing in, and they will add PEEP. So I inhale and I exhale. And there's always a little bit of residual volume in my lungs, correct? Keeping my alveoli from collapsing. But if I have ARDS where that surfactant has been washed out, my alveoli will collapse unless I leave a little bit of volume of air down there. So PEEP is like, as the person inhales, as they start to exhale, at the end of exhalation, the vent goes and puts positive pressure at the end of expiration. Positive end expiratory pressure. Does that make sense? It's at the end of expiration to try to hold open the alveoli to allow time for effective gas exchange. Yes? But we only want to keep it low, like 5 to 10. We don't want to get above 20 because I can actually blow that alveoli up like a balloon and lead to a pneumothorax. Okay? Think about this too. Another complication of PEEP is when I'm putting positive pressure in my thorax, I can comprise the heart and the aorta and the vena cava and prevent blood from getting back to the heart. So it can lead to circulatory compromise, decreased venous return. So PEEP does have consequences. Complications of PEEP, I just talked to you about that. Decreased preload, decreased cardiac output, and decreased blood pressure. Complications, ventilator-associated pneumonia, contributing factors of impaired client immune system, increased metabolic rate due to systemic stress, as well as paralytic ileus, tracheal ulcerations, accumulation of oral secretions loaded with bacteria, anemia, and when we're in an ICU, we're using all these invasive monitoring devices which can lead to infection, sepsis. Interventions to prevent ventilator-associated pneumonia. You need to know these. Keep the head up at 30 to 45 degrees. Wash your hands before touching the client. You should have gloves on. Perform oral care. That is my pet freaking peeve. You need to be in there, not with these little swabs. Get the toothbrush. You know what I'm saying? Brush the teeth. And rinse it with a little syringe and suck it all out and get all the stuff that's up there glued to the top of their mouths. That's where bacteria loves to hang. And then most of the ICUs have chlorhexidine policies where you're going to clean out their mouth with chlorhexidine. Suction, use oral swabs. Ventilator alarms, you do need to know about this. When an alarm goes off, don't stare at the freaking ventilator. Look at your patient, okay? Did they come disconnected? Like a low pressure alarm, that's usually because the alarm is going off because the ventilator is not meeting any resistance to deliver the breath. So the tubing connection between the endotracheal tube and the ventilator is not secure. So start at the patient and go backwards. If you're not sure, take them off the ventilator, grab your ambu bag, crank it up to 15 liters and start bagging the patient. Because when I give a breath, I can feel with my hand how much resistance I'm getting. If there's a high pressure alarm, okay, chances are maybe they have a mucus plug or bronchoconstriction. And so I take them off the ventilator, I get my ambu bag, and if I'm going like, dang, that's really taking me a lot of energy to ventilate this patient, there's something going on. So maybe they need an albuterol treatment and then I need to suction them, maybe there's a mucus plug. So a high pressure alarm means it's taking too much pressure to ventilate them. Think bronchoconstriction, mucus plug, they need to get suctioned. A low pressure alarm is they're disconnected somehow from the ventilator. Does that make sense? But anytime that alarm goes off, go look at your patient. Start with your patient. Okay, you can read through the rest of that because I got to get to DIC. Realize, we're going over in 2 hours what is you should take about 12 hours to go through. So you're going to be getting your lectures in class. I'm just trying to hit the highlights, okay? So some of this stuff you may not have gone over yet. Is that correct? Okay, because you still got this week before next week. So just kind of be hearing what I'm saying, and as you're reading, hone in on the important things. And then if something doesn't make sense, please talk to your faculty. Ask them, get them to explain it better to you. You can shoot an email to me, get down to NIP, whatever, because you want to understand these principles before you sit down to take your test. Okay, now we talked about all the different types of shock. SIRS, MODS, and one of the things of MODS would be acute respiratory distress syndrome. Okay, the other thing would be the effect on the hematologic system, okay? So we're going to talk about DIC, and you guys learned about it when we talked about OB. but we only learned about it a little bit, right? You just learned enough to know, okay, if I take a blood pressure and there's petechiae, DIC. Okay, so what we want to do is we want to go over this a little bit more so that you understand it a little bit more thoroughly. So it took me a long time to come up with this handout. Stay with me, okay? And then if there's anything that I need to re-explain, please just raise your hand, because this is not an easy thing to comprehend, okay? Once you work with a patient one time that has DIC, you'll be like, oh God, I totally see it now, okay? So I'll try to paint the picture for you as we go. So DIC, or disseminated intravascular coagulation, is also known as coagulation consumption coagulopathy. It's an abnormal response of the normal cascade system, that normal clotting cascade, caused by an underlying disease or condition. It's not a disease, it's a complication resulting from an underlying disease or disease process. Does that make sense? Okay. So here are some of the causes. Infection's a big one, guys. Sepsis is a huge cause of DIC. So anything that would cause SIRS, which we've already talked about. Obstetrical complications, that's where you first heard about it. Heat stroke, cirrhosis, a fat embolism, incompatible blood transfusion, snake bites, transplant rejections. Okay, so when somebody gets a venomous snake bite, if it's a hemolytic type of toxin, they go into DIC. That's how they die. So regardless of the cause, okay, DIC is a serious bleeding disorder, so they're bleeding, resulting from initiated and accelerated clotting. And we all know that when a clot forms, that's called thrombosis, yes? Okay, so causing generalized activation of prothrombin and an excess of thrombin. Okay, so prothrombin means I'm pro-clot, so there's a lot of this pro-clotting stuff going on in our body that leads to us making thrombin. And thrombin is the most powerful coagulation catalyzer, and it converts fibrinogen to fibrin. This is what I want you to think about. Fibrinogen is like putting fiber in a gin and making a spider web. Fibrinogen becomes fibrin. And when you hear fibrin, I want you to think of a spider web. Okay, I have a great picture of a spider web. When I do this lecture, I show it. A lot of times you walk outside and you walk into a spider web, you don't even see it. One day it was early in the morning and the dew had collected on this amazing spider web. You know how intricate and tight-laced a spider web is? That's what fibrin is. It gets laid down like this within your vessels so that when the little platelets, your platelets come through and they get to the fibrin spider web, what are they going to do? Get stuck and cause a thrombus. Yes? Okay. So fibrin gets laid down. So fibrin gets laid down. Think the sticky matrix of a spider web. And that sticky fibrin promotes platelet deposition in the capillaries. So this is going to really be most a problem in your smaller vessels. And there's going to be thrombosis and ultimately small vessel occlusion. Clots or thrombosis within the blood vessels, obviously if there's a clot, you're not going to get distal perfusion. So the decreased perfusion leads to those three I's: ischemia, injury, and if we don't correct it, what? Infarction. That's going to cause a buildup of lactic acid because they've gone from aerobic to anaerobic metabolism. They'll be in metabolic acidosis, and eventually whatever tissue is distal to those microclots is going to die. If that's the kidney, wherever. The excessive clotting occurring within the microcirculation usually affects the kidneys and extremities, but it can affect the lungs, brain, GI tract, adrenals, and pituitaries. Now you guys know that as soon as we clot, we have to keep hemostasis, right? We clot, then our body says, let's break down the clot. Yes, thrombolysis. So the excessive clotting process in turn leads to decreased available clotting factors. If I use up all my clotting factors that my liver produces, I'm going to keep bleeding, yes? Okay, so I've used up all those clotting factors. So I have low hypoprothrombonemia, I have low platelets, thrombocytopenia, and I have deficiencies in factors 10 and 13. Remember, you have the intrinsic and the extrinsic clotting cascades and stuff, and you have to have the different clotting factors to make them happen. You don't have to know those. Just realize you're using these up. If I'm using up my clotting factors, I ain't going to clot. I'm going to bleed. Yes? Okay. So the thrombin right? Which remember, thrombin is what helps lead to fibrin. The thrombin circulating in the blood vessel also activates the fibrinolytic system because your body says, oh my God, fibrin's laying down, we've got a thrombus, we need to break it down, which lyses or dissolves the newly formed clots. So when your fibrinolytic system kicks in, think about that little spider web getting broken up into a million pieces. That's called fibrinogen split products, yes? Or fibrinogen degradation products. And that will make sense when I start talking to you about what happens. If my little spider web breaks up into a million pieces, fibrinogen split products, fibrinogen degradation products, you're going to see those increase in the blood. Would you agree? So one of the signs of DIC is increased fibrin split products. Okay, that little spider web breaking up into a million pieces. Okay, fibrinogen degradation products, also known as fibrinogen split products, which actually inhibit clotting. So kind of concisely stated, DIC, disseminated intravascular coagulation, is a paradox of diffuse bleeding resulting from depletion of platelet and clotting factors. Once you use up your clotting factors and your platelets, you can't make any more that fast. Do you see what I'm saying? So this is the person you see that is bleeding and clotting. Now, here's your clinical manifestations. Bleeding or oozing from multiple sites. You roll the patient over and you realize that where your IVs are, it's oozing around that, or it's oozing around the catheter, or there's blood in the urine. They're bleeding from their gums. There's bleeding in the white of their eyes. You can see all that. Microthrombosis leading to bluish discoloration of their fingers and toes, kind of like acrocyanosis of a baby. Other related symptoms: dyspnea, oliguria, seizures, coma, severe muscle, back, and abdominal pain. That's never a good sign because you're clotting off those organs. And major organ failure. What are the complications? If you use up all your clotting factors and platelets, you're going to hemorrhage to death, leading to hemorrhagic shock, MODS. Now, this is what I want you to focus on. Here's the diagnostic studies. You're going to see, now think about it. You've used up all your clotting factors, so it's going to take longer to clot, yes? So your PT and PTT and bleeding times will be up. They'll be prolonged, correct? Yeah. And because it's breaking down that spider web, you're going to have increased fibrinogen split products, increased fibrinogen degradation products. And you're going to have an increased, circle this, D-dimer. That's the most specific marker for the degree of DIC, because it's a specific polymer that results when we break down that fibrin and not fibrinogen. So when that little spider web, the fibrin, when it breaks down, the D-dimer is going to go up, yes? So that's really specific to DIC. Now, I'm using up all my clotting factors, so my platelet and fibrinogen levels are going to be low along with all my other clotting factors. I'm going to have increased BUN and creatinine because it's clotting off my kidneys, decreased GFR, eGFR. Now this sounds crazy, okay? So what started this excessive bleeding and clotting was bleeding, yes? I'm going to put them on heparin. What the heck? Because heparin does not break up clots. What does heparin do? Prevents further clotting from occurring. So it's kind of hard, it's kind of like counterintuitive to see blood in the urine and I'm putting this patient on heparin. Okay, but that's what we have to do. We have to prevent further clotting. Because if they clot, they're going to further break down the clots, and this is just going to continue on and on and on. So my platelets are going to get used up. I will have to give platelets. I will give cryoprecipitate because it replaces specific factors 8 and fibrinogen. FFP. What is FFP? We talked about it earlier in hemorrhagic shock. Fresh frozen plasma. That's where all my clotting factors are except for my platelets. And I might have to give packed red blood cells, depending on what their hemoglobin is. Yeah, I know. It's overwhelming, isn't it? Okay, page 3, DIC, nursing diagnosis and related interventions. Obviously, think about deficient fluid volume, hemorrhaging related to the depletion of clotting factors. They're going to be fearful. If somebody goes into DIC and they have any consciousness, they're going to be fearful. Ineffective protection, these are all NANDAs related to abnormal clotting mechanisms. Risk for ineffective tissue perfusion. This is where you're going to start seeing like black necrotic areas in their fingers and toes because of the microcirculation. Risk factors, hypovolemia from profuse bleeding, and the formation of microemboli in the vascular system. So we want to monitor the patient's cardiac, respiratory, and neurological system frequently. Assess breath sounds, vital signs, watch their cardiac rhythm. Assess for signs of hemorrhage and hypovolemic shock. And remember, one of the places you can hemorrhage is your brain. A quick decrease in level of consciousness would scare me much more than a bruise somewhere. You know what I'm saying? Because I'm thinking, holy crap, they might be bleeding in their brain. Inspect their skin and mucous membranes for signs of bleeding. Observe color and capillary refill. Check IV and puncture sites frequently. Apply pressure to injection sites for at least 15 minutes. These people have used up their clotting factors. They have to be on high flow O2, watch their airway, watch their ABGs, minimize oxygen demand. So just like anybody that's on a ventilator, we're going to try to minimize the oxygen demands. We're going to give them sedatives. We're going to keep the room dark. You know what I'm saying? Keep them free of pain. Keep them in a semi-Fowler's position to maximize lung expansion. One thing I didn't mention, when somebody's in ARDS, the S was for save the good lung. Those areas of good lung are what we need to try to get the gas exchange to occur at, correct? So if they're really diffusely on the right lung, we'll keep them over on the left lung. And one of the things that we have done in ICU is we've actually done prone positioning, where we have the person on this bed where we can flip them prone and utilize the anterior alveoli. It's crazy, but it really works. We have to use whatever effective gas exchange area of the lungs there are. So frequent repositioning is huge. Monitor diagnostic labs. So we're going to be watching their PT, PTT, and their fibrin degradation products, which will all be up, correct? And their D-dimer will be up. Then all their clotting factors and their platelets will be low. We're going to be worrying about them clotting off their kidneys, so watch that BUN and creatinine, and administer blood products, FFP or platelets. Watch for transfusion reactions. These people are really a one-on-one. INOs are hourly. They should be in an ICU. Monitor for potential complications, including pulmonary emboli, acute tubular necrosis, which is where these fibrogen split products actually attack and clog up the tubules of the kidneys, and it can lead to multiple organ dysfunction syndrome. And then finally, provide emotional support to the patient and their family. Yes, love?
Is there any contraindications for using a Foley?
Is there any contraindications for using a Foley? You would have to have a Foley on this person. Most of the time when somebody goes into DIC, we have to tube them. They're going to be bleeding in their lungs. So we need to keep that constant look at the kidneys and is it bleeding there? What's our hourly urine? So yes, we're going to put a Foley in. And we'd have to be careful because the trauma of that is probably going to cause hematuria. But the good thing about a Foley is I don't have to keep putting the patient on and off a bedpan, which would increase their oxygen requirements and such, and I can monitor that urine coming out hourly, yeah? Plus, I can get with, the other thing that's nice about having a catheter in is that they can hook up to an internal core temperature monitoring, and I can tell what's going on with my patient's temp all the time. And that's in ICU, we do that all the time. All right, we went over a boatload of information. Are there any specific questions? And I need you guys to fill out the evaluations, and I know that it was fast and furious. For that, I'm sorry. I don't know how to take 6 weeks of information and put it into 2.5 hours any better than this. Again, if you have any specific questions, you can get a hold of me. You can stop me in the hall. You can email me. And yes?
How in depth do you want us to go in regards to like SIMV, controlled events, and all that?
Yeah,
stuff?
I want you to talk to your instructors about that. I don't think that there's probably going to go into depth in that. About, he's talking about the different modes of ventilation. Did you guys go do the roundabout with that? Yes. Okay, I would just understand it. Assist control is a very common, where we give the patient a tidal volume, say 700 mils, and we give them a rate of 8. But if they want to breathe at 12, every time they initiate a breath, we'll give them that extra volume to make sure that their tidal volume equals what it should be. A controlled mechanical ventilation, we don't do much. you would have to almost paralyze the patient to control their ventilation. Do you know what I'm saying? So cyst control is a very common. I would just know really more, I think, focus on what are the things you as a nurse have to be aware of with somebody's on a vent, that ventilator bundle, and how do we prevent barotrauma? Yes? And thinking about aggressive oral care, how do we suction a patient, how do we decrease their oxygen demands? But that's a great question for the faculty because I haven't taught for many years. So I don't even look at the tests because I don't want to ever be accused of teaching to the test, which I've never done. But I go by your objectives, you know, your objectives in your modules, and that's where you want to focus. If you can answer those objectives, you should be good. And I would encourage you to do practice tests, practice questions in ATI, on your adaptive quizzing. Anywhere you can get practice questions, do them. And then if one throws you, then get your faculty or me or somebody in NIPS to explain it, because that's all. It's the whole process. You guys get that now in level 4. You know, we've gone from knowledge to all application. There's a lot of application. And don't freak out about select all that apply. You know what you know, and then sit there and go, yeah, that's true, no, that's false. And the entire distractor has to be true in order to be true. Okay? Yeah? All right. You're very welcome, guys. Have a good one and do well on this test.